Welcome and good afternoon. I am Julie Kalkbrenner, one of the physician liaisons with Lurie Children's, and I'm joined today with my liaison counterpart, Chad Worley. Thank you for attending the Modern Antibiotic Utilization webinar. Dr. Sara Qazi and Jasmin Persch are eager to share current antibiotic prescribing information with you, the community provider. We hope that you find this virtual program valuable. This program is intended to be an interactive session, so please feel free to enter any questions in the chat box or question box on the right-hand side of your toolbar. Today's session is being recorded and will be emailed to you by the end of the week. Please feel free to reference the recording at your convenience. I would now like to introduce you to Dr. Sara Qazi, site leader for the NM Huntley Pediatric Hospital-Based Medicine team.
Good afternoon, everyone. First of all, thank you so much for joining us. We are super excited to reintroduce the Lurie Children's program for the hospitalists here at Huntley. And while we do that, to introduce our project. As you know, we are a small group of hospitalist pediatricians who have been taking care of the area kids, most kids from your practices for the last several years here at Huntley. We do admit from Woodstock, from McHenry, and from Huntley EDs. We're happy to take consults. We're happy to take ER consults. If anyone would like us to see their kids in the ED, please call us on our phone. We have our number right up here. Talk to us. We'll be happy to see them in the ED. We also are happy to take telephone consults if you just want to get into our brains, so to speak, and just talk about some kids. Or if you think there's a sick kid you want to transfer out, we're happy to do that for you as well. We are 24/7 in-house at Huntley and are available for your consult. The other thing I wanted to talk about was the fact that our team has changed slightly. We have several new members. We have, I'm going to introduce Dr. Jasmin Persch in just a couple of minutes, who's joined us recently, and we have a couple of new members coming in. I will make sure that Julie, at the end of this session, will send out an email with our new team members to all of you, so you are aware of who is there. As far as our project today is concerned, it's called BASIC. It talks about the best choices for antibiotics that you can select in children. Literally, that's what it stands for. We are going to be talking about 3 different, very, very common diagnoses that you and I and all of us see in the community, meaning skin and soft tissue infections, UTIs, as well as community-acquired pneumonias. And the main aim of this project is to talk about how we can narrow down the antibiotics to as much as possible, decrease or optimize the length of the antibiotic treatment, and go ahead and distinguish our first and second line antibiotics from each other. We have created algorithms, pathways, clinical care guidelines to help all of us work together to treat these children, because the main thing is, if we are sending these patients out from the ER as well as inpatient on these narrow spectrum antibiotics, we want to make sure that when they're in the community and they can be treated outpatient, all of us are on the same page. So having said that, I will now introduce Dr. Jasmin Persch. She is one of the newest members of our Huntley team. I'm going to hand over the talk to her, and she's going to talk about our project. Welcome, Jasmin.
All right, thank you, Sara. Okay, so I'm going to share my screen. And then we are going to turn our videos off while I'm showing the slides. Let's see. Okay. And can you guys see that okay?
Yes.
Okay, thank you. All right. So I'm Jasmin again. I'm one of the hospitalists at Huntley, and I'm really excited to share this QI project with you guys, since we are making outpatient recommendations on antibiotics, and that's mainly going to be our PCPs in the community. So you guys could really make a big impact with this project. So BASIC, again, it's just about antibiotic selection in kids, mainly, as Sara was saying, going with the narrowest antibiotic that covers the main bug, as well as the shortest possible duration that is going to effectively treat the infection. Let's see, it's not advancing, so let me. Oh, there we go. Okay, so our objectives for today is to review the epidemiology as well as the local resistance patterns of the 3 infections that Sara mentioned. So skin soft tissue or SSTI, urinary tract infection or UTI, and then a community acquired pneumonia or CAP. And then we're going for the most appropriate antibiotic choice for these 3 infections, as well as the most appropriate duration. So just to look at basic a little bit closer, again, the 3 infections, and it's really a type of antibiotic stewardship program that we're bringing to the community hospital, as well as now also our community providers, where often these programs are missing, and we don't even have pediatric antibiograms to look at. So we are implementing this in previously healthy, well-appearing children. Of course, if they look toxic or septic, there are different antibiotics that we would recommend for them. And then for the most part, more than 2 months of age, just because in those first 2 months, of course, if there's a fever, we're more worried about sepsis. And then for pneumonia, it is going to be above 3 months, just because the national IDSA guidelines, that's where they draw the line at 3 months. Under 3 months, we're more worried about something sexually transmitted like chlamydia, so the bugs are a little bit different. So the cutoff is just going to be a little bit later. And then we are making recommendations for the inpatient setting for kiddos that we have to admit to the hospital in the ED and discharge. And because we are making those outpatient recommendations, we wanted to extend our project to the PCPs in the community, so we can really streamline care inside and out of the hospital, which is very exciting. And then again, we are making recommendations on duration, empiric antibiotics, as well as definitive. So any chance we get, we should try to get a culture, particularly if there's an abscess that we can drain. And then for UTIs, we always want a culture to really confirm the infection. And then for pneumonia, it's really rare that we actually have a culture for them. So as far as just antibiotic use in the US and locally, half of the antibiotics that are prescribed for children are inappropriate. So that could be duration, or the choice is too broad, or unnecessary, which we probably know, often kids will just have a virus and they just don't need antibiotics. We collected baseline data for this project, and it really showed, and this is for the Huntley Hospital as well as Woodstock and McHenry, that there is great variability in how antibiotics are prescribed in our kids. Here we have just for SSTIs, but depending on the month, certain months providers were nailing the antibiotic choice, and other months it was a coin toss. As low as 50% were the blue line. And then for duration, certain months we were completely off on the duration, other months we were nailing it. So with this project, we really want to streamline care because these are common infections. And then combating antibiotic resistant bacteria in kids is really great, because then we can start them off on the right foot for the rest of their lives. So we're building tools to help our providers, because we know giving talks, it's easy to forget what's been said. So we want to give our providers something to review. We've made ED clinical pathways that have recommendations for oral antibiotics as well, which we want to share with our community providers. And they will also have a dosing table, as well as an antibiogram that we use to choose the antibiotics that we recommended, so that our providers can actually look at the table and decide for themselves that, yeah, this is a good choice too. We are available by phone as well as email if there are any questions or suggestions. We welcome a dialogue with you guys. And then I just want to look at each of these infections individually. So starting with skin soft tissue infections. So first, the epidemiology. We really break this down into purulent and non-purulent. So purulent abscess is kind of the typical one, and there we want to cover Staph aureus, including MRSA, which that really changes our antibiotic choice. And then for non-purulent, which cellulitis is kind of classic there, so we want to cover Streptococcus pyogenes and MSSA for non-purulent. For kids with cellulitis, we do want to assess for MRSA risk factors, because if it's positive, then we're inclined to cover for MRSA too. So that changes the antibiotic. So that would be, you know, did that patient have a prior MRSA infection, or did anybody in the family or somebody that they're kind of, you know, who's at home or they're hanging out with for extended period of time. Or if they failed the first line for non-purulent, then we worried, okay, we weren't covering MRSA and it's not getting better, so now we need to cover it. Or something like recurrent pustules or boils, penetrating trauma, and then IV drug use, which we could get in a heads exam from a teen, for instance. So as for the local resistance pattern, so what we're aiming for is we want pathogen susceptibility to be 80% or higher. So that's our threshold for first line antibiotic, and that's what the IDSA kind of puts out. So as for non-purulent infections, we're recovering Streptococcus pyogenes and MSSA. Keflex or cephalexin actually works beautifully, 100% susceptibility. So that is going to be our recommendation for first line. And then I know where I trained in residency, clindamycin was the go-to for a purulent infection. And, I learned here that it does not work well in our community. And then just to let you guys know, this is a pediatric antibiogram from Lurie's, which we think applies well also to the children in our community. And so, yeah, if we look at clindamycin under MSSA, both and MRSA, they do not meet the 80% threshold, so we cannot recommend it as first line. We are recommending it for folks who have allergies as second line, because it is still going to work the majority of the time, but not as well as Bactrim. So our Lurie Peds ID, who we've been working closely, I should say, with other hospitalists at Lurie outreach sites, as well as Lurie Peds ID, pharmacy, as well as ED providers, to come up with these recommendations, as well as the AAP, who is behind this whole QI project. So yeah, so our Lurie Peds ID is recommending Bactrim first line for MRSA, and then we can see Bactrim works 98-99% of the time for Staph aureus. So, and then here it is again, kind of spelled out, and I'm just quickly going to review this pathway with you guys. So basically, it starts at the top with a well-appearing child more than 2 months of age. We do have exclusion criteria, which you can probably imagine if somebody's immunocompromised, you have to go broader if they have a foreign body, if they recently had surgery, if the infection is over a joint and you're worried that maybe there's osteo, there's a bite wound, if there's an infection involving the teeth or around the eye, perineal or adenitis, then we're excluding them. Those are the coverage is going to be different. And then, obviously no routine labs, ultrasound only if you're not quite sure there's an abscess, but you think there may be one there. And then again, for purulent, IND is really part of the therapy as well as the diagnostic. And then we want the gram staining culture. We do have admission criteria, which maybe if for community providers, if you're worried, do I need to send them to the hospital? That those could be helpful. And then again, for purulent, first line would be Bactrim. And then we also have, if somebody has a sulfa allergy, we do have clindamycin there for somebody who has an allergy. And then third line, we have doxycycline for kiddos who are 8 and older. And then the IV recommendations are more for our ED providers. And then on the non-purulent side, again, we want to make sure they don't have MRSA risk factors, which would bump them to the other side. And then the first line is going to be Keflex. And then for cephalosporin allergy, again, clindamycin. And then as for the duration, we are recommending 5 to 7 days. And then of course, it's great to if it's cellulitis, or an abscess with surrounding cellulitis, of course, to kind of draw a line around it and make sure that it's getting smaller, and then reassess before stopping. We do know that there's going to be people who are an exception to the rule, and they're going to need to be on antibiotics a little bit longer, and that's okay. So for the majority of people, 5 to 7 days should be definitely long enough. And then overall, the goal for our project is to kind of keep the majority, 85 to 90% of people, within 7 days. And then one of the things I know that has changed a lot is whether to do antibiotics after doing an IND on an abscess. And so I just wanted to touch on this briefly. So the data out there are pretty mixed, and there are a number of studies that show no benefit, but there are randomized controlled trials that do show higher cure rates when you do antibiotics compared to placebo, and also a reduction in having to do another IND, or having the abscess recur, or having the skin infection spread to the household. And of course, we're going to see more side effects if we are given antibiotics. Particularly, we see a lot of diarrhea. So overall, we do feel like there's enough of a benefit as far as just recurrence and spread to doing a short course of antibiotics after doing the IND. And then quickly, I want to touch on Impetigo, since we do see this often in our kiddos. So Impetigo, the main bugs are going to be group A strep and MSSA. And then interestingly, the IDSA guidelines actually say to do gram-stain culture, which I haven't really seen done routinely in practice, but they do recommend that. And then we know that for limited disease, we're going to do topical antibiotics, and it just depends on which topical antibiotic, but for mupirocin and retroamulin, I usually use mupirocin. 5 days is the duration for these. And then if it's more disseminated, or there's kind of an outbreak in a preschool or in a household, then oral antibiotics are recommended. And Keflex works very well against these two. Of course, if you do end up getting a gram-stain culture, or you screen them for MRSA risk factors and it's positive, then you might be inclined to cover MRSA as well. And then the duration that IDSA recommends is 7 days, which is within what we're recommending for basic. And then I wanted to move on to UTIs. So for UTIs, the epidemiology it's mainly gram-negatives. So gut bacteria, E. coli, overwhelmingly more than 80%. And then we are seeing an increase in ESBL kind of resistant gram-negatives, but they're still less than 1%. So our first-line antibiotics do not need to cover them. So it's a growing threat, but it's still a small threat overall. And then as for our local resistances for E. coli, again, our threshold that we would like to meet is 80%. So here we kind of looked at, these are different Lurie outreach sites, our antibiograms kind of side by side next to the Lurie one as well, which is all the way to the right. So overall, a pediatric antibiogram is generally kind of better than a pediatric adult antibiogram, but here we actually decided to go with our Huntley's, the HH in the second or in the third column, just because the kids that get admitted at Lurie Children's, they are going to often have complicated UTIs with urinary tract anomalies, and that's driving up their resistance rates compared to us in the community. It's just a different population. So for Huntley, when we look at cefazolin, which cephalexin is going to be the PO equivalent, it does meet the 80% threshold at 82%. And then overall, when we look at resistance in kiddos who have infections who are treated outpatient, the resistance rates are actually lower than inpatient, which we can probably imagine. Because the folks who fail outpatient, they end up having to come in. So we're expecting for the kiddos that you guys are treating that the susceptibility is even better than the 82% that we're seeing, which is combined inpatient and ED data there. And then even Lurie is actually recommending Keflex for ED discharges because the resistance is lower for people who are treated outpatient. Okay, so so for antibiotic selection, the AP group that we're working with for basic is recommending first generation cephalosporins where there's high susceptibility to E. coli, and that's that 80% threshold. There have been a number of QI initiatives who've used first generation cephalosporins, and we wanted to see if there's any consequences from doing that. And they have found that there was no significant increase in revisits or inpatient admissions, or it didn't drive UTIs, and they're on antibiotic that doesn't cover it. Interestingly, 84% actually improve in the first 2 to 3 days, despite being on antibiotics that really shouldn't cover ESBL. But that definitely supports using a narrow spectrum as first line while waiting for the urine culture results. And then other studies have also showed that being on kind of the wrong antibiotic, the children still had similar durations of fevers, as well as rate of clinical improvement and microbiological, which probably just means clearing of the bacteria in the urine. So here is our pathway for UTIs, and here we're recommending Keflex first line, and we also have recommendations for kids who have a cephalosporin allergy. So PO Bactrim would be recommended for them. And then for sulfa allergy, we have the option of doing PO ciprofloxacin, which is broader than we generally like to give. But if somebody has an allergy, has multiple allergies, then it's the only thing we kind of have left. You can do nitrofurantoin as long as it's just a simple cystitis, which is typically in kids who are 2 years and older. And it does not penetrate the renal parenchyma, so you can't give it to somebody who has pyelo. So any kid who has a fever or flank pain or anything like that, we can't do nitrofurantoin. And then, of course, if it ends up being a gram-positive, like Enterococcus, amoxicillin would be the go-to choice there. The data on the duration for UTIs is a little bit confusing, and nobody really knows the exact kind of optimal duration. But we did look at the evidence to pull these guidelines together, and overall, we're trying to go for no more than 10 days for an uncomplicated pyelo. So for there is a study that looks at kind of 6 months and older, and saying that 7 to 10 days would be appropriate for them, and then under 6 months, we're just leaving it at 10 days. And then for simple cystitis for teens, 12 and older, we can do as short as 5 days. And then for simple cystitis, 2 to 12 years, 7 days is appropriate. Okay. And then lastly, move on to pneumonia. So the epidemiology for pneumonia. So for under 5, it's mainly viruses. So it's completely appropriate to forgo antibiotics in younger kiddos. And when it is a bacterial infection, which is much less common, it's something like pneumococcus, streptococcus, even more rare, Streptococcus pyogenes and Staph aureus. And then for children 5 years and older, again, pneumococcus. And we really see atypical pneumonias in kiddos 5 years and older, like Mycoplasma, Chlamydia, pneumoniae. And we don't typically see them in the younger children. As for workup, routine chest x-rays are not recommended for mild pneumonia, so for particularly for outpatient, as well as if they come into the emergency room and it's just mild. And then viral testing, if they do test positive for the flu, that can change our management, and if that's what you're suspecting. And then antibiotics would really only be appropriate if we're thinking there's a co-infection. Mycoplasma testing, if you're able to do that, it could help guide the antibiotic choice, since it would be more of a macrolide in that case. And then as for the exclusion criteria, children less than 3 months, of course, if they're trach vent dependent, if they have lung disease other than asthma, which we see a lot of, and then symptomatic or cyanotic congenital heart disease or kind of acquired heart disease. And then the antibiotic selection for pneumonia is amoxicillin. If the children do have a beta-lactam allergy, we can give them clindamycin, and then second line levofloxacin, which is quite broad. So of course, it's not something we want to give first line, but if there are multiple allergies, we have that as an option. And then as for just vaccine status in younger children under the age of 5, if they are under vaccinated for their age for Hib or pneumococcus, you can consider Augmentin, although the AAP basic group is saying amoxicillin is still an option, but because resistance are a little bit higher, you can consider doing Augmentin there. And then if you're suspecting atypical pneumonia for children 5 years or older, macrolides would be the go-to. And then as for the duration, interestingly, there's a new study from this year in JAMA Pediatrics, which was comparing 5 days versus 10 days for mild pneumonia with amoxicillin, and actually found that 5 days was not inferior. We are currently recommending 7 days, with the goal being no more than 10 days. And as for the route, when we compare PO amoxicillin and IV penicillin, there's no difference in clinical outcomes, and of course oral is going to be more cost effective, so we always prefer oral. Amoxicillin, of course, if the child has mild pneumonia and isn't requiring oxygen or anything like that and can tolerate oral medication as well as fluids. And that actually already brings me to the end, and I would love to just open the floor to any questions or comments.
Thank you, Dr. Persch. This is helpful. We do have a question, although I think it may have been answered in your presentation, but just addressing the length of time of treatment for SSTI, is that 5 to 7 days? Is that right? Yes,
that is right. And we'll just go back to that here. Okay. Yeah. So overall, we're recommending 5 to 7 days, and then our goal is to try to not be longer than 7. But if you see the child on the 7th day and the infection isn't gone, then you have to tailor it to that patient. So so even though, you know, we put out guidelines, of course, each patient is a little bit different, and we know they're going to be outliers. And so if you know, one patient needs, you know, 8 or 9 days, then that's what they need.
Okay. Okay. All right. And then what about, are you finding any, beyond the study here, are you finding any more any additional like resistance to antibiotics with these kids, or you haven't really discovered anything like that?
No, I mean, yeah, so we are just kind of rolling this out, but the QI studies that are out there that kind of support doing this, going with the more narrow antibiotic choice, have not found that there's an increase in resistant bacteria. And overall, I think there's an argument for if we do treat patients with more narrow antibiotics, that we are helping against kind of creating more resistant bacteria.
And just to add, this is Sara, just to add to this, the whole idea that we put in the antibiogram was because to start with the fact that we are using antibiotics that are not resistant. You know, the bacteria are not resistant to it. And that's why the antibiogram that's geographically appropriate for our Huntley area was used in making these algorithms for now. And going forward, we'll just have to keep reassessing.
Excellent. Okay, thank you very much. I think that wraps it up for the question section for our program today. I just want to thank all the attendees for coming today. This is great information. I'm sure the providers will look forward to implementing it in their daily practice of seeing patients. I want to thank all the attendees and for the participation with the program. You will be receiving a recording of today's program and by the end of the week, and you will have access to this recording for about 1 year. Lastly, before we close it out, I just want to let everybody know that Lurie Physician Services is now on social media, so please follow us on Twitter, YouTube, Facebook, and LinkedIn. So you will also be kept updated on any other virtual programs that we'll be having like this. Thank you so much, Dr. Persch and Dr. Qazi. We appreciate the information you're able to share with our providers. Have a good day, everybody.
Thank you.
Thank you.